Good afternoon and good morning. This is Mark Fendrick from the University of Michigan Center for Value-Based Insurance Design. We'd like to welcome you to today's webinar, VBID-X, a new plan option for the individual insurance market. This is a webinar brought to you by the VBID Center at U of M and the Health Markets and Regulations Lab at Harvard Medical School. If any of you are tweeting out there, you see our hashtag VBID. I look forward to seeing your tweets. The next slide. So there you see my picture. Happy to be having many of you from all over the country taking time out of your busy schedules. And we're excited to launch VBID-X. Today's one-hour program will be divided into a number of sections. First, this welcome, and I'll give you a little bit of background and motivation for VBID-X. I'll introduce our panelists, and then you'll have a presentation by Professor Michael Chernew from Harvard Medical School. We'll have our panel reaction, and then we'll have question and answers. You should be able to see a question box on your screen. You could enter questions throughout the program. And importantly, you will be able to have access to our documents discussed on VBID-X in the handout section on your computer. So today we're joined by four very knowledgeable individuals regarding health insurance exchanges and the individual marketplace. I mentioned Michael Chernew, my close colleague for many years, who's director of the HMR at Harvard Medical School. We're also very pleased to have three panelists, including Greg Gierer from AHIP, Lourdes Grindal-Miller from CSIO in CMS, and Peter Lee, who's the executive director of Covered California. We will kind of go through a rapid fire, have Mike go first, hand it off to Greg, Lourdes, and Peter, and then we'll open it up for questions and answers for the remainder of the hour. So many of you know about value-based insurance design. This is an idea that Mike and I put forward almost 20 years ago, a benefit design program that sets consumer cost sharing on the clinical value, not the price of services. While we've had some implementation in the private sector, in the Medicare program and the TRICARE program, implementation of VBID has slowed for a number of reasons. I think two that are most notable is the lack of a standard VBID plan. Mike has been asking me to create a template or a prototype plan for nearly 2 decades. I could tell you that I'm thrilled and horrified the fact that we're launching this prototype plan called VBID-X today. I think the other main reason for the suboptimal uptake of value-based insurance design is there's been a lot of concern regarding the cost impact or the return on investment that comes with the increased utilization of high-value services, particularly those whose cost sharing is lowered in a value-based insurance design high-value service type model. So to address these two issues, we felt that benefit designs incorporating clinically nuanced VBID principles or cost-sharing approaches would be particularly attractive in the exchanges, given the lack of flexibility concerning premiums and plan deductibles. So when we would do these VBID carrot programs, or those that led to increased use of high-value services, plans would typically respond to that by either increasing premiums on all beneficiaries or increasing plan deductibles or other out-of-pocket costs on those who utilize high-value services. A big movement forward in the VBID arena has been our attention to the identification, measurement, and reduction of no or low-value care, in the fact that now we realize that we could build a VBID plan that lowers cost sharing for high-value services, that raises cost sharing for low-value services categories, and importantly, does not increase premiums or deductibles. We've had a lot of purchasers, public and private, ask for a cost-neutral VBID plan, and Mike finally convinced us to go ahead and build a template, which we call VBID-X. So to talk about the process of how we came to the VBID-X prototype and introduce you to the template, I turn it over to my close colleague, Mike Chernew.
Great, Mark, and thank you, and thanks to everybody who's taken time to come and listen to the webinar today. The discussion I'm going to go through now is going to be relatively brief, so I want to emphasize a point that Mark made in his intro that may have gone by too quickly, which is there should be a handout that links to a broader report that's on the right side of your screen that will allow you to learn much more about the specifics of what we did and how we did it, sort of at your leisure to look through. But let me go through the broad set of guiding principles for what we were trying to do, motivated by the fact that on the exchanges in, say, a silver plan, there really is considerable cost sharing for individuals, and that was particularly worrisome for me, and I would say Mark as well, because that means people with chronic conditions often face significant financial barriers to accessing services that are important. So our goal was to come up with a concrete plan that could actually be implemented as opposed to just a general statement of make high value things less expensive and low value things more expensive. We wanted to be very specific about what those things were. And as a result, we were trying to go through a very specific exercise, not a theoretical or conceptual exercise. And in doing so, and I must say in a moment, I'll talk about the folks that went on this journey with us, but we learned the enormous complexity and how hard it is to actually build any type of health plan, particularly one that meets VBID principles. So we were trying to anticipate and address barriers as we went through this process. So for example, it would be important for insurers to be able to take what we've done and implement it. So we were worried about things about their ability to adjudicate benefits and a whole series of other things. And in that process, we realized that the best can't be the enemy of the good. Our goal was not to have the perfect VBID plan. Our goal was to make a step forward towards the type of plan that could be implemented, and then, of course, make the output of what we've done publicly available. And again, you can see that on the handout, what we've done. So next slide. So in doing this, we did it with a small group of really knowledgeable organizations to help us address some of the implementation and other issues and make some of the complicated choices that arise when one's building a type of health plan. So that includes Covered California. You'll hear from Peter Lee later. You'll hear from Lourdes from CSIO at CMS, and we have Blue Cross Blue Shield, the Massachusetts Health Connector, and AHIP, and Greg is going to be on the as a panelist in a little bit as well. It was all supported by generous support from Arnold Ventures, so thanks to them. And in doing this, of course, the actuarial estimates are crucial, and I can't give a big enough thanks to our friends from Oliver Wyman that provided the actuarial estimates to everything we did to get the scoring right. I think people underestimate the importance of scoring for anything that one does. So next slide. So our basic approach was simple. We picked a base plan. We did this actually at a number of different levels, but for the purposes of this, we had a silver, a relatively standard silver base plan. I realize there's a whole range of different silver plans and different designs, so relatively typical silver base plan, so roughly a 70% actuarial value plan. Then we identified high and low value services. It's one bullet point, a ton of discussion, and then we went back and forth to try and get the high value services to have lower cost sharing, and with the help of Oliver Wyman, then to figure out how we could offset that with various types of low value services. Much more detail on that is in the handout. The goal in doing that, again, in part because we were constrained by the 70% actuarial value, we would have no increase in premiums, and we wanted to do it all without having an increase in the deductibles, which have caused a lot of concern broadly. So next slide. So the whole project consisted of 4 meetings and a bunch of work between the meetings. The first meeting was to bring the group together and discuss the issues, the ground rules, and the processes. A lot of these questions about how nuanced we could be in picking high and low value services. So for example, a service is not high value for everybody necessarily. It may be only high value for some subset of people. So there's a question about that level of granularity, what would be implementable, and a whole series of other related issues. about how we were going to go about doing this. Then the second meeting was really concentrated on the high value services. What are the high value services? And then between, there was a lot of iteration with Oliver Wyman to score what that would do. If all we did was lower the cost sharing on the high value services, what would that do to our actuarial value? And then once we knew that, we had the third meeting, which was to identify low value services and go back to Oliver Wyman to get scoring on the low value services. And then much more time than I ever thought would take was spent trying to balance the high and low value services so we could retain the same actuarial value. Next slide. So some of the basic principles for which services we wanted to favor involved picking ones that had the strongest evidence base and external validation, services that would be more responsive to cost sharing. So part of this is to help encourage consumers to use high-value services, and we would want to pick high-value services to which we thought consumers would respond to lower cost sharing. One of the things that came up very early on in that first meeting is we have to really be worried about the complexity of the plan. Simplicity is really important. So we've tried to minimize the type of nuance so you don't have dramatically different cost sharing for the same service based on your clinical condition. We were very worried about communication and complexity and a whole series of issues related to that. And then there's a range of other considerations like the equity issues, adverse selection, and of course your view of that depends on what you think is going on with the risk adjustment models, impact on special populations, and then the overall risk pool, what's happening between the exchanges and other populations. So I'm not going to read all these services, mostly because I can't pronounce many of them well and Mark will mock me, but you can see on the slide a list of the services that we consider high value to have reduced, largely actually eliminated cost sharing. There's a whole range of services there, and then we'll linger for a second and then we'll go to the next slide. There were a series of drug classes which were high value for which we recommended reduced cost sharing, understanding that when folks implement this plan, they may still want to retain the incentives for to allow competition amongst the branded drugs. So it might not be every drug, or that would be up to the plan, whether it was every drug or just some drugs in class, but these are the classes that we identified as high value. Understanding that having a high value plan is not just using the right services, but also purchasing these services efficiently. So that requires some maintaining of competition between different sets of products. But these are the high value branded classes that we focused on, and go to the next slide. For a series of low value services, we had some specific ones, things like spinal fusion. I'm going to skip over you know why I'm skipping over it, vitamin D testing, and I can say proton beam therapy for prostate cancer. So those are examples of some of the low value services. Next slide. Vertebroplasty. See, I said it for those keeping score. Then in order to make it balanced, we had to pick a set of services that are high value in some cases, low value in other cases, but overall we considered services that collectively might have some limited value and have modest increased cost sharing on some of these services. What makes them useful in helping maintain the actuarial value is that they're widely used. So we had marginal changes to outpatient specialist services, x-rays and some imaging, high-cost imaging, non-preferred branded drugs, for example. So we increased cost sharing on some broad classes of services to maintain the same actuarial value in the plan. Next slide. So I want to emphasize that if you look at the handout, you'll see these lists, all the sets of services I went through will be listed in the handout. Understand that this is just one version of what a plan design could look like. Whether or not the numbers balance in your population will depend on the characteristics and the utilization patterns of your population. So people would have to do their own actuarial analysis. Although we think it would, broadly speaking, come close. And of course, you may make other choices than we did about how to balance the high and the low value services, not just which services, but how much to reduce the cost sharing or how much to raise the cost sharing, given what your interests are in the process that you typically go through. So while Mark was correct, I pressed him for a long time for a concrete plan, which I did, and he did deliver. We have at the end an example of a plan, recognizing that anyone can come up with somewhat different choices. So the key points are selection of the high-value services, the level of cost-sharing reduction for those high-value services, picking the low-value services, deciding how much to increase cost-sharing for those services, and then building it around a particular base plan. We picked silver. You could have done gold. I'm particularly personally worried about what's going to happen in bronze, which at least in Massachusetts has a significant market share, and we may have been very successful in getting people coverage, but we really have to worry about whether or not that coverage removes the barriers for managing chronic conditions and accessing a number of other high-value services. So this is one concrete example. We hope it begins the conversation. We certainly don't think we have the best possible plan or that it's in any way the end of the conversation. Next slide. So the key takeaways are that it is possible to do this. You can build a VBID plan. You can do it without raising premiums, without changing the actuarial value significantly, and without raising deductibles. There's a large number of plausible combinations of services and ways to change it to make that work. What you'll see in the handout is one example of how we've done that. Next slide. And so, given that sort of breadth and flexibility, we have three terrific panelists to discuss from their perspective this whole initiative and its importance and where we're going. And so I will turn it over now to Greg Gierer, who is the Senior Vice President for Policy at AHIP. So, Greg, thank you.
Thank you so much, Mike. Good afternoon and welcome, everyone. Very pleased and honored to be here on the webinar today to talk about our involvement in this initiative, about basically applying the principles of value-based insurance design to the exchange marketplace. This has been an 18-month-long effort that has involved multiple stakeholders, including plans, state and federal officials, and leading experts from the field, including academic, actuarial, as well as clinical. And special thanks really go to Mark Fendrick and Michael Chernew for both hosting this webinar and really helping to spearhead this important initiative. AHIP has been a strong supporter of this concept for many years, and VBID principles have been successfully adopted in other market segments, including among large self-insured employers, among state employee programs, including in Connecticut and Oregon, and in the Medicare Advantage program, which has been now, this model has been expanded to all 50 states, and tens of thousands of Medicare Advantage beneficiaries are benefiting from lower copays or additional enhanced benefits due to their chronic conditions. The concept of eliminating and greatly reducing cost sharing for high-value services, especially treatments and drugs to treat chronic conditions, holds tremendous promise in reducing financial barriers to needed care, improving adherence to prescribed treatments, and achieving better health outcomes. For this group, designing a VBID plan for the exchange marketplace is complicated by the fact that plans need to meet specific actuarial value targets. That means reduced cost sharing for high value services need to be offset by increasing cost sharing for low value services such as expensive imaging or non-preferred brand name drugs when a generic equivalent is available. And given that this is a price-sensitive market, the exchange market, designing a VBID plan for the exchange marketplace should be done on a cost-neutral basis. That is, no increase in premiums as compared to a standard base plan. So with that in mind, this group came up with the solution, which is VBID-X, a prototypical benefit design for the exchange market that eliminates or reduces cost sharing for high-value services without increasing premiums or deductibles. This is really a template of how VBID can be implemented, but it importantly is not a one-size-fits-all. As far as AHIP's role in this initiative, we were very focused on, from a plan perspective, on what is feasible and realistic. This is from both an actuarial and pricing perspective, from a cost and budgetary perspective, from a risk pool stability perspective, as well as kind of from a pure operational or benefit administration perspective. A couple of principles that we brought to our engagement was, number one, really focusing on increasing cost sharing for targeted service categories that are more likely to be overused, as opposed to increases in general cost sharing and deductibles. As everyone here is well aware, there's been a trend of increasing deductibles in the employer market, and deductibles in the exchange market, at least for those who don't qualify for cost sharing assistance, are high. And this has been shown to reduce both high and low value care, and a particular risk for those with multiple chronic conditions who would forego needed medical care because of cost. So being mindful of deductibles and implementing VBID in a way so that deductibles don't increase was an important priority. Second is kind of being mindful of operational and administrative barriers to implementation, and looking at this from a pragmatic perspective, as Michael mentioned at the outset, not letting the perfect be the enemy of the good. And then finally, building in flexibility in both plan design and management to assure that it can be successfully implemented. This pertains to both the specific services that are targeted for the VBID intervention, as well as the ability for plans to manage costs of the enhanced benefit, kind of consistent with current best practice standards and clinical guidelines. So to sum up, we believe this is initiative, and VBID-X is a very important way to improve the quality and value of insurance coverage, especially for millions of Americans with chronic conditions. And while this culminates an extraordinary effort in producing this paper, it's really the beginning of the process. And the challenge now is kind of take the findings and insights from this important report and work towards implementation. And so looking forward to engaging in dialogue with my colleagues here and those on the webinar about the best way to move forward. And so with that, I'm going to turn it over to my colleague Lourdes for her remarks.
Thank you, Greg, and good afternoon, everyone. I'm pleased to join you today, and I'm particularly pleased that I was allowed to join the group of esteemed members to work on the VBID-X project. As CMS, of course, we are always looking for innovative plan designs that can offer enrollees high quality, affordable options. And so we want consumers on the exchange to have access to innovative options that are available elsewhere in the market, and we want to support these models to contribute to the overall affordability of healthcare. We were interested in working in VBID-X because it was based on research with the goal of increasing affordability and improving access to appropriate care. And the fact that we're particularly drawn to the project because issuers and state-based exchanges were involved. It was and rounded out with Mark and Mike and other folks. I felt that this was going to come up with a helpful project or product, and we would have something tangible that we could kind of move forward with. And I do believe we have that. Now, what I would say, though, is there are definitely still challenges and opportunities to this work, and I think achieving this template is a good step, but there are a whole bunch of other considerations we need to think about. And I know that Greg kind of discussed these a little bit, and I'll go over I'll give you my take on these items also. I think that from the consumer perspective, as we need to think about the educational and operational lift to display these different options to consumers and to educate them and help them understand what VBID means. And then within CMS, of course, there are, and CIO, just decisions that must be made in terms of budget and priorities, and how we implement any improvements year over year. We want to create a space for issuers to have VBID plans and support the offering of products on the FFM that are affordable and high quality. And quite frankly, the opportunity already exists. If an issuer would like to offer a VBID plan, that is possible. But in essence, what we're thinking is what's a way to kind of encourage and see issuers can offer this on a VBID plan on a more consistent basis. And I think prior to that, and this is something that, Greg has talked about a little bit, is issuers need to perceive this as being worth the investment. But I think, with the participation of AHIP and BCBSA on this group and our continued kind of coordination and discussions with them, I think we can get there. So one of the other things that we are thinking about here is how does this work with risk adjustment? Because the current plans are geared towards handling chronic care conditions and, making sure that the model can handle, in air quotes, this approach. And then additionally, and I know we have Peter Lee speaking after me, and we had the Massachusetts connector participating, we need to find a way to give state flexibility. Each state has different rules. Some have standardized plans, others have mandates and the like. And so trying to allow for some flexibility there so that VBID plans can be offered across all the states. So as an issuer, so in terms of how to get involved with VBID-X, as an issuer, I would suggest, obviously reviewing the report, look at your current plan offerings and how they could potentially be modified to include this VBID cost sharing, and of course use the newest AV calculator to kind of try out these different designs. And then I think separately, anyone who's interested, I'm going to give a plug for the report that is in the handout section, and I think that goes into much further detail of what Mark discussed, and you'll get a better sense of what that implementation could be. So kind of looking forward on VBID-X, we're definitely looking to see how this is received by the issuer community and by other stakeholders. And we also would like to think about at some future time, what does how could this model be used for the average consumer so it doesn't necessarily skew towards chronic care? I think the other thing that was sort of difficult here is very easy to identify high-value services, but when you have to identify low-value services, that's when it gets more difficult to be able to kind of make this an AV and premium neutral effort. And one of the other things that we kind of ran into was kind of the operational nitty-gritty of the problem of clinical nuance. So, certain procedures might be effective for a subpopulation, but not on the whole. And how do we message this? How is it implemented in the claims processing systems of issuers, and a whole bunch of different sort of operational considerations there that I think we need to delve more deeply in order to be able to kind of continue to expand what would be a low or a high value service. And then we also want to hear comments from the public and, like I said, other stakeholders on the consumer approach and how we could display and market and kind of generally educate consumers on this, on VBID. So it's kind of a variety of things. It's always more complex than the template, but I think the template was an amazing step to get us to, a concrete implementation on a larger scale. And I'm really excited to work with everyone to kind of continue in implementing this. And I think with that, I would like to turn it over to Peter Lee so he can talk about the California experience.
Lourdes, thank you for the handoff, and thank you to the entire VBID team that's done this really good work. I want to do two things in my brief remarks. One is set a broad context for how VBID fits in what's happening in the individual market, and then identify, similar to Lourdes, some of the opportunities and challenges with actually doing this practically. And one of the things I appreciate is the work here flags that this is not about theory. We out here in, whether you're in a health plan, a provider, or an exchange, we're doing designs every day. And this is a very real world exercise. So first, context. I'd remind all of us that under the Affordable Care Act, defining essential health benefits is itself an exercise in value-based design, identifying which 10 sorts of care should be covered. Second, under the ACA, provides a framework by establishing a benchmark plan. Within that, states and the federal marketplace have a lot of opportunities to apply different benefit designs that can either be value neutral and provide for a lot of range for variation among plans, or be very value centric. I would note that California, and for those that aren't familiar, Covered California is the marketplace for the state of California. We have about 1.4 million individuals enrolled through the marketplace, and another about 900,000 in the individual market off exchange who don't get subsidies. Virtually all of those 2.3 million people use the same patient-centered benefit design that Covered California has designed in concert with health plans, actuaries, consumer advocates. They use the same patient-centered design. I need to repeat that again, because we in California have designs that mean if you are in bronze, which 25% of our subsidized, on exchange people are in, they get 3 office visits and lab work not subject to a deductible. If you're in silver, gold, or platinum, no deductible ever applies to outpatient care. So you see a primary care doctor, you do not have a deductible between you and your doctor at all. That's a value-based design right out of the gate towards the goal that is central to VBID of encouraging people to get the right quality care, and the belief that that will lower costs overall, but definitely lead to better quality. So that's part of the context. The other context for us in California is, and I appreciate Michael's note of this, is who are we speaking of addressing? Because for marketplaces, on exchange is not just about bronze and silver. It's silver and enhanced silver because of cost sharing reduction subsidies. I remind all of us that, for example, in California, 50% of our enrollment is in enhanced silver because of cost sharing reduction subsidies. We have in California 50% more people in a silver 94 product, which is a 94% AV silver, than we have in the standard silver. And that standard patient-centered design for that enhanced silver means it's a $5 primary care office visit. It's $8 for an x-ray or diagnostic. So there's already value investments in design with cost sharing reductions that are affecting many people. That said, in particular for people who are chronically ill, who are not at a silver 94 but a lower silver, and in particular for people without subsidies that may have right now a deductible between them and getting any outpatient care, let alone people with chronic illnesses, there are huge opportunities for better value-based design. So it's in that context that I'd note a couple things. We in California are looking closely at building on our current patient-centered design, which are benefiting, again, about 2.3 million Californians, both on and off exchange, by piloting extensively more robust value-based design. In doing that, I'd flag 3 major issues that I think need to be considered. First is this one option amongst many available to consumers, or is it the option? And is it the option that is available on a marketplace or on and off a marketplace? And the reason that's such a critical question is, as Lourdes noted, issues around risk adjustment are big issues for plans. You may have a carrier which is able to design a great VBID program, which unto itself is cost neutral, But in doing that, if they are having a VBID program which has good benefits for people with diabetes, coronary disease, it may shift VBID, the risk adjustment, maybe to their benefit, maybe not. And how that plays is a whole nother layer of thinking about this. We are looking at this more as a benefit that should be everybody gets it. It is cost neutral to everybody, but it would be a common design like we currently have. So that's one issue. Second issue, and again, I think Lourdes touched on this really well, is the challenge of trade-offs of how do you fund in the near term high value services against low or lower value services. Now, our goal in doing this work is to have higher value services supported so it lowers total cost of care. Until we've developed really good proof points on that, though, we need to make it transparent in the AV calculator and have offsets. Some of those are easy, but I would note in virtually all the domains of commonly used quote-unquote limited value services, it is absolutely the case that some x-rays are of limited value, some outpatient surgery is of limited value, some high-cost imaging of limited value. But in every one of those domains, there are people getting care for services that are very, very high value. So having the right balance of trade-offs against raising costs for outpatient surgery, for x-rays and diagnostics for people that need those services is a consequential issue in terms of weighing how much the value is for getting more people into that high value care. The third big implementation issue to my mind is looking at these designs from the perspective of both patients and providers. And the very good roster of potential services outlined in this material provides, 30 or so either services or drugs that relate to a range of conditions, a range of patients that could touch on many people. In particular, if you're looking at both antidepressants, statins, glucose lowering, these relate to people with risk of coronary disease, people who have mental health issues, people that might have diabetes. And a challenge with that is who are you seeking to communicate with and what the designs are, what they mean at a patient and well as a provider level. I'd note that our starting point in considering this is to be likely more focused and say, let's look at the bundles of services and drugs for particular chronic conditions to expand later. So do you start with diabetes, coronary disease, asthma, and look at both services and drugs for those before going much broader in areas that may not have as clear of a proof point for the near-term payoff as opposed to others that may be more proven. And again, those are all balancing acts, but all of those balancing acts are framed by our agreement with the underlying principles. We should be doing a better job making sure all of our benefit designs are not discouraging people from getting the right care at the right time. That's what VBID's about, and Covered California is thrilled to be participating in this effort now, and we'll be working on this in the months and years to come. So with that, I'll turn it back to the facilitator moderator to see if we have questions or comments.
So we've had a lot of questions come in. And I think what I'm going to do is ask the questions and have the panelists answer them in the reverse order which they presented. So Peter, Lourdes, Greg, and Mike, I'm going to combine the two most prevalent questions because they are somewhat linked. The first is, and Peter, you touched on this nicely, is just hopefully it'll be a fairly straightforward answer, is generally, how do we feel about the idea of increasing cost sharing on targeted services that are deemed to either be specific low-value care or high-value care? Peter, you know full well I would much rather have high-cost imaging for patients undergoing low-risk back pain on our list, but in this first prototype, for reasons that Lourdes mentioned, that's going to be very difficult to do. Hopefully VBID X 9.0 will have that. And the second is, all four of you, if you could also respond about what you think the appetite might be regarding the administrative issues and the claim processing issues of actually getting to a more nuanced plan. The main reason why we ended up with these baby steps is there was significant pushback from all the organizations represented to really put in something very nuanced, which Mike and I have talked about for many years, but even something as straightforward as eye exams for people with diabetes was, although agreed upon unanimously as a high-value service, you see it did not make it on the list because some of the plans said they were not able to adjudicate a differential cost sharing for some group of patients as opposed to others, which why our guiding principles took us to this fairly straightforward list that we called in the group as fruit below the ground. So Peter, low value care appetite, because you've been expanding benefits, and primarily your barriers have been through the typical instruments of cost sharing across the board when they're applied, and deductibles, to actually picking out certain services that we'd really like to see less. And your thoughts on down the road more nuanced designs that incorporate some of these clinical aspects that often aren't seen in a claim scenario.
Yeah. So first, I think it's exactly the right question. It's the ambition in the VBID-X was to say, don't affect deductibles. I'm not sure if that's going to be possible, quite honestly, because we in California have in our patient-centered design already put more cost sharing on services that are relatively lower value. Primary care visits are $40 at a standard silver and $5 at a CSR 94. However, specialty care is 2x primary care. That's a conscious choice around trade-offs on lower and higher value and having less barrier for people to get in to see a primary care doc. So this is going to be not easy, because there are in every of and I totally agree with you, there are absolutely high cost imaging for low back that are really low value, but those don't happen enough to get you 0.5% or 1% of premium to trade off against what we need. So it's going to be a tough hope, the road to hope. On administration, I think it's absolutely the right question. One of the things we are working with our 11 carriers in California is if we are having standardized VBID-X, on which areas can we administer, can the carriers administer common benefit designs and payment systems for things like no copay for 3 or 4 visits a year for a diabetic, but copays for others. And that administration issue is in some ways a initial starting point question, as well as, again, it's not just administration on the provider side, but making sure consumers know about it. I just want to note that consumers don't understand deductibles right now. If we're talking about other issues, we need to think about consumer and provider administration.
Thanks, Peter. Lourdes?
Sure. So I think on the low value care and the appetite for that, like I said earlier, that I think that was probably the most difficult part of the work we were doing. And I think that by coming out with this report, gauging reaction, seeing how the implementation goes, and sort of taking an iterative approach to looking at how to introduce these, the higher cost sharing for low value care, and just kind of continual monitoring. I think that and I know hearing from Mark and Mike that, maybe at first it's not understood or well received, in maybe other experiences, but just kind of continuing to work at it, and it might be gradual progress, but I think we would make progress. In terms of an appetite for to a more nuanced plan, I think a lot of it comes down to having more in-depth discussions with issuers and with the people in charge of communicating to consumers, and of course that varies depending upon, where, if it's the marketplace or other places. But I think that we in the VBIDX group knew more or less where the challenges were, but I think if we can get more information, get more comments, then we can start building towards the nuance and seeing, well, which ones are easier to implement from a claims processing perspective, for example.
Greg, how about you?
Thanks, Mark. Yeah, I think I agree with my fellow colleagues here on the panel about, basically how to finance these enhanced benefits, which are so important, was a critical part of this group's work, and is, a challenge. I think we both want to, one, provide incentives for high value care, but we also want to create disincentives for low value care. And I think the goal really should be along the lines of kind of targeted and clinically nuanced. So having those higher cost sharing for low value services be carefully targeted. But, as my fellow panelists have mentioned too, there's issues there around claims adjudication and simply administering the benefit. And then also the more targeted, on low value services, the less potential for cost savings to finance the elimination of copays or reduction in copays for high value services. I think, as this goes forward, we can take some heart to the fact that, under the Affordable Care Act and $0 cost sharing for preventive care services, that's administered in kind of a clinically nuanced way, in the sense that it's specific services for specific populations and specific patients. So these are obstacles to doing it in a clinically nuanced way, but they are not, as our experience has shown, insurmountable obstacles. And I think, as far as this report and this effort, it was about striking the right balance between, what's possible from a clinically nuanced perspective towards what's practical from a benefit administration perspective.
Thanks, Greg. Mike, how about you?
So, as you know, the elimination of low-value care has been high on my list of interests and research agenda and other work we've been doing about low-value care. One thing that this project illustrated was how hard it is to get at that specific low-value care because of operational reasons around nuance, but also questions like whether or not we can expect cost sharing to be the right mechanism, whether we can expect consumers to be the right stakeholder to eliminate various types of low-value care. Those issues forced us to move towards the principle I mentioned early on, which is we wouldn't want the best to be the enemy of the good and accept some noise in the set of services. By noise, I mean some high and low value in the set of services that we raised cost sharing on, in order to really favor the services that we thought were very important and very high value. That's a very complicated set of trade-offs. I would much rather, and I think much more research should be done and work should be done on figuring out how to get at the existence of low value care. I do want to point out one last thing about this. There are things one might do to save money. One big issue, not for this particular webinar, but a huge issue we're focused on, is the price of care overall. Whether you're buying services or whether you're buying, DME or drugs or whatever it is, that's a super large issue. That can't be dealt with in the benefit design space. But if one does deal with that, the way the actual value calculator works is you don't get credit for that. So you're forced to go through some version of this type of exercise, and that forces you to have a somewhat imperfect plan. The more work we can do to identify low-value services, generally speaking, the better. And as you know, this was the beginnings of that. It's certainly not the end. But one thing I realized in this exercise is, put a lot of energy into low-value care, you will be able to find places to spend any savings. It's much harder, as Lourdes said and others, to find where the low-value care is and decide what to do. And that's where we have to focus our attention on, recognizing various constraints in trying to solve all of this problem with consumerism. And so I'll just say, for those that might not be clear about this, we didn't do this, I think, because we think consumerism is the fundamental way to solve the problems in the healthcare space. We did it because on the exchanges where we had, the benefit designs were by necessity not as generous in particular areas as we thought were important. And so we were just trying within that construct to build a plan that was better, not solve all the many problems the healthcare system faces.
Thanks, Mike. I promise we will do our best to answer all the questions that have come in, including those that we don't have time to address. I have a big smile here in Ann Arbor with our VBID Center team because there are a lot of people asking to see where they could buy VBID-X now, Mike. So unfortunately, VBID-X is not currently available, but one of the goals that Michael Chernew had from the very beginning is to see uptake, hopefully in the individual market and exchanges. But there have been a few questions which I'll take a short stab, and then you, Mike, can chime in, and then I'll open it to the other panelists. What about the role of VBID-X in settings not in the individual marketplace or exchanges? And there was a couple comments and questions about the new IRS guidance regarding what could be covered on a pre-deductible basis for chronic disease care in health savings account qualified high deductible health plans, or HDHPs. So Mike, I'll take HSA HDHPs and you could take other non-exchange situations. It's really interesting for those who have not heard, after 14 years of Mike and I working on to change an esoteric IRS guidance to allow pre-deductible coverage of high-value chronic disease services in HSA HDHPs, it's in the last week where the Department of Treasury went ahead and approved this change in a group of specific diagnostic tests and drugs to treat chronic conditions. It shouldn't surprise anyone that those services overlap very nicely with the high-value services that were selected by the VBID-X group. So it is our hope that moving forward, that something like VBID-X, just because of what's happened within the last week, so we timed this webinar well, that something like VBID-X can in fact be implemented. Please remember that in our high-value services, with the exception of 2 classes of branded drugs, we reduced cost sharing of our high-value services to 0 to be most conservative, and we're not actually recommending that plans do cover these services at 0 cost sharing from consumers, but certainly don't make patients pay the full price, which is somewhat similar to what Covered California did for ambulatory visits. So we're hopeful to see VBID-X implemented in places outside of the exchanges. For the reasons that were mentioned by many, we felt that the exchanges were a perfect place to explore this, because historically, when we convinced payers to spend more money on high-value care, they tended to either think about raising premiums or deductibles as opposed to these more specific low-value care cost-sharing increases. And I think it's also worth mentioning before I turn it back over to Mike that under no circumstances do we think that this first prototype is anywhere near where we want to stop. There have been a lot of comments and questions about, can you use VBID-X to steer people to site of care or other types of programs that plans and providers use to improve quality. We like to think that VBID-X and VBID designs in general just seem to reinforce many of the other programs that are putting into place to better spend our healthcare dollars. Michael?
So thanks, Mark. Briefly, because of the unique institutional features of the exchange, particularly the need to keep within a particular actuarial value band, I think the nature of this project, which involves trade-offs, is really important. That said, across the board, we're facing rising cost sharing in this country because our fundamental problem is a problem of spending. And to the extent that the high and low value services identified in this project can be helpful to folks outside of the exchanges, I think that that would be a wonderful way to sort of build on the principles of this more broadly, understanding that when you're outside of the exchanges, other things that can help you control spending besides raising cost sharing, for example, become really important. So addressing some of the fundamental problems in the system around price, for example, ends up being particularly important, but not a solution in the actual value sense on the exchanges. So I hope that this is much more generalizable. I'm thrilled that there's interest beyond the exchanges. The key, we use the word exchanges, but what you should really hear is we really meant we use the exchanges to give us what that base plan is to start out with. If you go through this exercise yourself, you'll see you'll get different results based on if you're at a gold or platinum. So if say you're working in an employer with an 80% actuarial value, the numbers would be different than at a 70%, which is what we modeled in silver because of the non-linearity of the way benefits designs work. And then the exchange context forced that discipline of maintaining the same actuarial value, which you wouldn't necessarily have in another context. But to the extent that, for example, here, where we try and think of our benefit design that we will offer to employees, we, like anybody, would like to have a benefit design that helps protect those people with chronic conditions and make sure they have access to high-value services while really reducing the use of low-value care and, frankly, overpriced care. And to some extent, we can do that through benefit design, and hopefully we'll move further down that path as an employer later.
Thanks, Mike. So as we are in our final minutes, we're going to go to our rapid fire round. Greg, Lourdes, and Peter, in that order, please. I'll thank you again after your last minute, but thank you so much for your contribution to this project and participating today. Many people refer to Chernew as myself as Tigger and Eeyore. You guys could figure out which ones that are, but how about 30 seconds on where you see VBID-X? Are you buying or selling? Greg, Lourdes, Peter. Greg first.
Thank you, Mark. Yeah, this is Greg Gierer with AHIP. From our perspective, I think the future of VBID is very promising and very bright. I think the template that has been produced by this group, while relevant, most relevant to the exchange marketplace, absolutely can be applied to other markets. And, for the 15+ million people in the exchange market, having additional options around value-based insurance design is an important way to enhance insurance coverage and produce better health outcomes. And I think the challenge will be, taking the findings and results of this report and implementing it, in state exchanges, potentially the federal exchange. And AHIP looks forward to working with our partners to assure successful implementation.
Thank you, Lourdes.
So I thought you were going to ask me what character I would be, and I was thinking either, I don't know, Owl or Christopher Robin. But in terms of this, I feel that there is promise, and I think change is incremental, and we've got a very good, first step here to kind of start the process.
Thank you. Peter, last word.
Yeah, a quick note is, first, I think that the individual market, which I think I'd bracket this as not just the exchange market, is both the best and worst placed to do this. And I'd note that because we have actuarial value, but we have insured products that need to have payoff in 1 year. In the employer market, self-funded, they can look multi-year. I think one of our challenges is to have something that is both near-term payoff, but many of the chronic care payoffs may be over more than 1 year. And we're in a churn market, so that's going to be a challenge. But I think that for all the reasons we've all said, it's the right place to place big bets on, and Cover California will certainly be doing that.
Well, thank you, all of our panelists and all of our webinar registrants. I want to, this is just the beginning of VBID-X. A recording of this webinar, as you see on the slides, will be available. We will send that all to you. It is our hope that you'll please share the recording as well as the resources that were available widely. And we'd love at the VBID Center to hear from you, your points on VBID-X. You see in front of you a link to the VBID Center's website, which has everything you want to know about VBID-X, including the slides from today. And as I said, we're going to do our best to answer as many questions from those that we didn't address. Last thanks to Arnold Ventures, Oliver Wyman, who we tortured many, many times to get the actuarial estimates right, our program managers, Jason Bucksbaum and Michael Boudros, And lastly, Susan Lynn Osterly and the VBID Center staff who made this webinar go as well and smoothly. So I thank everyone. I wish you all a great remainder of your day and look forward to hearing from you in other venues. Goodbye.